My name is Danny Sammons, and it's like Simmons with an A, Sammons. And I was born in Longview, Texas in 1960. I've been an East Texan, been here most all my life. I moved away for a couple of years. But I probably just missed it. I came to work for Avail about 8 years ago. I haven't been with the company quite as long. I was in administration at a little university called Laterno University in Longview, Texas for a number of years. And then I was on staff at a couple of churches. And then I went and transitioned to psychotherapy and psychology. And now I'm a LBC supervisor and have done, I did therapy, inpatient, outpatient, geriatric work, and then work with executive function testing with the psychologist in Longview, mostly with children. And then Jamie, the owner of Avail, called me one day, said, "Hey, come over. I need a clinical director," and talked to her about it. And I've been there ever since. So crisis work is near and dear to my heart, not because it's crisis, but because there are so many varying forms of crisis. And you see it from young children all the way through, especially when I did geriatric work. It's unbelievable how many people are suffering in silence in crisis. And so I forget who the poet was that said most men live in, quiet desperation, live lives of quiet desperation. So you never know until you start visiting with them. And so I want to visit with you a little bit about crisis work. And Lana, do I just do the up arrows to get back? Yeah. Let me tell you a little bit about Avail Solutions. You can go to that website. It's availsolutionsincorporated.com. Find out what we do. Our mission statement's pretty generic, but we do work in the professional behavioral health service, which involves all the catchment areas that we serve is about 60% in the state of Texas. Yes, ma'am? No, the Avail Solutions is in Tyler. We actually have two clinics. We have one in Tyler, Texas, one in Corpus Christi. It started in Corpus Christi and then moved to Tyler because there were just some needs for some contracts we had with what they call LMHAs, the local mental health authorities, which y'all will be familiar with, the Andrews Center, Community Health Corps, Burke Center. And then in the Dallas area, it's NITBA and Tarrant County, all those. But we contract as crisis services with 26, I guess, out of the 39 mental health centers in the state of Texas. So we cover the vast majority, about 200 in something counties, I think 230. We're unknown by name in the state of Texas, but everybody knows what a crisis line is. And so is the head office here in Tyler? Or is it yes, it's here in Tyler. We started in 1999. We cover our catchment area covers live bodies, about 13 million people in the state of Texas and Alaska. We have some contract with Alaska specific. Don't know how we got those, but they needed crisis lines and they called us and they pay, and so we do that. As I was saying, we have an office in Corpus Christi and Tyler, and we have what's called QMHPs, which is qualified mental health professionals, and they get 3 months of training. They have an undergrad degree in social or psychological degree forms, and then they get that certification under an organization called the AAS, which is the American Association of Suicidology. Believe me, that's a real organization, and unfortunately, it's needed because there's, as you know, you don't have to look at too much news to realize what the rate of suicide involving not only veterans, which is separate from what we do, but the rest of the population. And so we do continuing education, just like your volunteers. And then we have half of our staff are actually individually certified through AAS, which is intensive training for suicidology, which is the study of what causes people to have suicidal thoughts, things like that. We staff our crisis lines 24/7, 365. It's always open. We don't ever take a day off. We have Spanish speakers, and then we utilize also any language line. We have people call that we're speaking Swahili and every forms. I mean, I think Indonesia has like 7,000 islands down there and 150 different dialects. And so we'll find someone who can translate at some level using the language line. So Let me go ahead and I'm going to get through some of this just kind of as housekeeping, so it gives you a broad example of what we do. We handle crisis calls, which is anybody that feels like they're in a mental health crisis. The individual mental health centers have their own crisis line number. Like Andrew Center has an 800 number. I'll visit with you a little bit about 988 later because it's an adjunct to what we do. But if you call 988 based on your area code on your number, you'll eventually get routed to Texas if you have a Texas area code. But we handle what's called overflow for 988. So when the four major 988 centers get full, we have a division that answers those overflow calls. And so we actually answer some 988 calls, but for strictly crisis work for Andrew Center, Community Health Corps, the local mental health centers that you'll be dealing with, Access Mental Health Center down in Jacksonville and Palestine, we handle those direct crisis lines. And we already talked about this.
What is the acronym OSAR stand for?
Oh, I'm sorry. I did want to cover that. It's called Outreach, Screening, and Referral. It's actually the state-funded substance abuse program. So when somebody calls in and says, hey, my brother needs treatment for alcohol use, or my son's addicted to fentanyl, meth, whatever, we if they don't have funding through private insurance, we give them what's called an OSAR referral. We have numbers and different processes for different centers. Sometimes we call a worker. Sometimes we just give them the number, but we screen them for lethality on every call. We'll talk a little bit about that because I think that's something you guys can put to use. But so it's a substance abuse form or referral. And a lot of there's some overlap in the mental health centers, but every county in the state of Texas has one of the centers covering it for OSAR services. And so it may be East Texas Council on Alcohol and Drug Abuse, or it may be another, I think some of them even are contracted with Senate or some of the private agencies, but that's what that is. So when somebody calls, if you notice it says crisis intake, OSAR, managed care, specialty support, and emergency screenings. Real quick, and I'm sorry, I'm gonna have to go back if this clears the screen. Crisis is anybody that calls, oh my gosh, my son just broke all the windows out of the house. He's on drugs. I don't know what to do. Or, oh, my son just took off, said he doesn't want to live anymore, and I don't know where he is. We handle those kind of crisis calls, even down to small children, and sometimes especially small children. We get a lot of calls from schools, school counselors. A child made an outcry in class. They didn't want to live anymore. They cut themselves. So those are the crisis calls. Intake calls are more like my school counselor calls, says she thinks my child might have ADHD or some kind of behavioral problems. We need to get them checked out. So we would help them schedule an intake. We schedule for some of the centers an intake to get in services with the mental health centers for an evaluation and to see what kind of services they may need. So that's what our intake appointments are. OSAR, we just covered. If you need substance abuse treatment, don't have funding, then we provide the resources, a referral for that. In managed care, you may have heard of Driscoll Health or El Paso Health. Some of the health programs that we call them, they're managed care insurances. They offer, sometimes they're not really not an employee assisted program, but a company may have a specialty insurance with Driscoll Health. And so they have Star Kids. They have basically a form of Medicaid or public funded insurance through these organizations. And so we handle calls for them too. We screen for lethality, and we even answer a call for a nurse advice line. So we don't have nurses on staff. We did that at one time, but that was another story. We don't want to talk about that, keeping nurses busy. But we handle calls for a nurse advice line. If they have medical issues, we'll call the nurse on call and have them call back. So that's outside of the crisis area a little bit, but we screen all of our calls for, are you feeling suicidal? Do you have any risk that would need to be addressed from a mental health standpoint? And then specialty support, we handle one of our 911 districts. We handle Aleutian and Alaska areas because it's such a broad area. They have very limited resources. And so we help people that call from that area get in touch with their local sheriff's office or local mental health hospitals. And then emergency screenings, we do what's called a emergency outreach screening, which is an assessment where our QMHPs that we talked about, our qualified QMHPs, actually can sit down and spend 30, 45 minutes, maybe an hour with a client, and we refer them to a state hospital. And so we're kind of the gatekeepers of the state hospital funds, because as QMHPs, you can't just go to a state hospital and say, hey, I want to go in the hospital. Here's my Blue Cross. They won't take that. They're there for state funded referrals. And so QMHPs, which are the way our people are trained, are those people. So we actually, and that's where I come in. I spend a lot of my time doing that, going over those screenings, making sure they meet TAC code and the legal standards. Sometimes it's involuntary, and so you get into all that with the doctors and hospitals and jails, and so we have to refer people for inpatient hospitalization to keep them safe or their family safe. So we do some of that. As you can imagine, the jail calls, we get quite a few of those. There's a lot of people that are suicidal or psychotic or have some kind of a major crisis where they can't be safe in jail. So we've already gone over this, 26 mental health centers. We can cover 230 counties. That kind of shows you an idea of the coverage. All the ones in yellow we cover. All the ones in white are some of the other large individual crisis lines. They have their own crisis line services, but we cover the vast majority, I think, of at least landmass in Texas. Let me see if I can talk to you about the lethality screening, because this is something I think you can make use of, and I'll let that go. But a lethality screening is to determine how at risk a client is or someone is when you visit with them. If you're in, I'm guessing when you go to a home or you have interaction with a client or a parent, I'm not sure what level of interaction you have on every front, but between the child or the client and then that parent, we would pay attention to both the risk for that parent and the child, because you're going to engage in having a parent who may be in the middle of having a child removed, and they may have substance abuse problems. They may have been involved in the justice system, and so I know that puts them at a higher risk to begin with. Some of the racial dynamics and the ethnic dynamics put them at a higher risk. And so as you're talking to your clients, we're going to talk a little bit about what red flags go up and how you can respond to that. And I know you have your individual protocols and your policies for CASA. Don't let what I say contravene any of those. Obviously you need to follow the policies and training that CASA puts forward. But if you are in a home, and I'll just get really to nuts and bolts here. If you're in a home and you have a child or you have a parent or a caregiver that's at risk, here's some of the reasons you could call the crisis line. And the crisis line, each one have their individual lines. I'll actually give you a number for those that you would use for Smith County. But if somebody's saying, hey, look, I don't want to live anymore, or I just want to kill my ex, he's not paying for child support, or he beat me up, whatever that is, they make a homicidal statement. I don't know what your duty to report comprehensive training is or what you have, but if somebody makes a statement like that, that would be a reason to call the crisis line. I've actually had police that call the line and say, hey, can you talk to this person? I'm not sure they're at risk, but I want to make sure they're okay before I let them go. They were walking down the road, pushing a shopping cart with a coat on in July, talking to Jesus. Okay. It's okay to talk to Jesus and walk down the road, but not in the middle of the July. And especially if you say he's telling you to do things that aren't legal or would put you at risk. And so the policeman called and said, hey, can you talk to this person? All of our people are trained to do this lethality training. Do you feel like you want to hurt yourself, or what's going on? And we do that interview. And so we would make a referral in the community. Maybe they need OSAR training. Maybe they have a drug addiction problem or a substance abuse problem. Maybe they have a family member who's refusing to get help, but they're putting themselves or their children or themselves or their community at risk. You would need to know how to get a hold of the right law enforcement to get involuntary what we call emergency detainers or mental health warrants through a judge. We would help give that information to someone who calls us. And so anytime somebody's experiencing symptoms of depression, bipolar disorder, schizophrenia, or anxiety, those can put them at risk. That doesn't mean if somebody's depressed, you would call the crisis line. We all have intermittent depression, but if somebody's experiencing an ongoing descending depression, or if you're in a home and you see somebody who's deteriorating physically or emotionally, that's reason to at least get a second opinion, get some eyes on them or some ears, listen to them that is trained to pick up on what those risk factors are. And so you can use the crisis line. We want you to use it. It's not a talk line. It's not a, let me tell you about my Aunt Mamie and how mean she was to me at Thanksgiving. That's great. You need to talk to somebody about that, but that's not the reason you would contact a crisis line. So anyway, we could do all of those functions. That would be a reason, all those listed there, that you would give us a call at the crisis line. The outcomes, when we get through with talking to the crisis line, we don't just end up and say, okay, have a nice day, and hang the phone up. We're going to try to get an outcome that's both helpful to the client, that's acceptable to the client, and we feel like is the maximum amount of help we can give them while we've got them on the line. I always refer to the use of the crisis line, that when it rings and one of our people answer it, say you call in from a home, you feel like somebody's at risk. If you call in, you hand us the baton, and our job is to get it to the next referral source as fast as we can, as safely as we can, with the right outcome. And so the reason, what I say with that is we want to make sure the client's okay with it, that they feel like they've gotten a reasonable service, you and yourself as well, that you didn't feel like, well, that didn't do any good to call the crisis line. We don't want that kind of outcome. We want you to be able to say, hey, that was a good resource. I didn't know that was here in Tyler. I didn't know that was available to us. So we want to provide that. The most high intensity, I guess, or the most extreme would be maybe an involuntary commitment or involving law enforcement, where someone was taken against their will for evaluation because they were such a danger to themselves. Say they were going through extreme psychosis, or maybe, and if it's drug induced or not. I was talking to a law officer one day, and he said, well, we're not mental health professionals. We shouldn't have to come out and deal with mental health patients. And he said, it's just meth. It's just meth use. And I said, well, if somebody's on meth or somebody's schizophrenic and they're still running in the highway, they're still running out in front of traffic, you have to be involved because it's public safety. That's why we get you involved. I know you're not a mental health professional and we're not legal professionals, but both of us, in a sense, are responsible for public safety. And so police sometimes have to be involved. We don't like it. It's the last thing we want to do is have to call police, but we will. We give them coping skills. Have you tried breathing exercises? Can you stay away from the guy that makes you mad? Do you have a place to go? We give those people that call in on the crisis line, they'll call in at 2, 3 o'clock in the morning. I can't sleep. I'm having a panic attack. And so we'll actually talk with them and give them some interventions that can help them ongoing, not just that one time. And so our people are trained to do that. And then again, we do if a mother calls in about her son that's not willing to get help and he's at risk and she feels like he's going to hurt himself or hurt somebody else, we'll help them explain the involuntary system to them, kind of what they might need for their area. Do you call a judge? Do you call a mental health deputy? Do you call a local police officer? So we help them navigate those waters. And then we also refer to the local mental health center. Sometimes they just need some counseling. They maybe have depression, they have grief, they lost their spouse and they can't get over it. They have complicated grief. And we'll refer them to the local mental health center for an intake appointment where they can talk to them about the options for having personal counselors and one-on-one counseling. And in fact, the mental health centers in the state of Texas cover a broad range, all the way from psychotropic medications being provided, seeing a psychiatrist, down to, hey, we just got peer advocates that will sit down and talk to you for a week or so, or once a week or so, try to kind of help you keep stable. And so they have everything in between. So it's a good resource to use if you're not aware of it. And some of you may be well aware of what they do, but if you're not, it's not a bad idea to get online and go to Andrew Center's website, see what services they offer. Same with Community Health Corps. If you have clients outside of, I don't know, is this strictly?
Smith Transient would, so it should
okay.
Be people that live in surrounding counties.
Gotcha. So, but Andrew Center here They have for IDD clients, they have a clubhouse option now where they can go and work and serve in a client run house. And so there's some opportunities for some of the clients that y'all might encounter that need mental health services. This is what the crisis line should not be used for. We're not counselors. I am, but I don't. Our QMHPs are not there to do counseling. They're crisis workers. Because counseling in the state of Texas will get you in trouble if you advertise you do counseling. You are bound by the legal requirements for counselors in Texas, whether you are one or not. If you advertise it, that's why a lot of pastors need to be really careful when they say, I'm going to be a counselor. Well, you're going to get sued one day and you're going to be held to the standards of confidentiality and everything else. So we don't provide counseling services on the phone. We provide crisis services. We don't call, hey, I need to talk to my case manager. You know, if they called and said, hey, I had a CASA advocate come by and they said my case manager was supposed to call me and they hadn't called. That's not we're not an answering machine, we're not an answering service. We don't give medical advice. We don't talk about medications. We don't talk. Now, if you cut yourself and need to go to the hospital, yeah, we're gonna help get you. Call a police officer to get out there so he can arrange for an ambulance. We'll tell you to put pressure on the wound and stay with you on the line. But we're not going to tell you, oh, cut back on your blood pressure medicine if it's making you feel bad. We're not going to do that. Okay. Don't talk about refills and stuff. We don't increase the appointments. We don't speak on behalf of the mental health center, and we're not a warm talk line. Tell me about your first boyfriend. We're just not, that's not what we do. Now we don't just say, oh no, I can't talk to you and hang the phone up, because we're going to peel the onion. We're going to talk to you long enough, because a lot of times when people call a crisis line, they're not real forthcoming with what there really is going on in their life. So we kind of help find that out by doing what I call motivational interviewing. So what was that? Yes, we do. We start out here and get down to those hard questions sometimes. But we don't want to, if somebody's questionable whether they should call the crisis line, we don't ever want to say, oh, I don't think that's good. I'm not going to call them. No, call us. They'll tell you if you're at the right place or not. We'll absolutely let you know. And we'll try to give you a referral. Intake services is single point, we call them SPOEs, single point of entry. That's basically for mental health, emotional disorders. Monday through Friday, we're contracted with 9 different centers. So we actually set up or refer to an intake line. And we do screen everybody for homicidal, suicidal, psychosis, or deterioration on every call. So that's the big benefit of using the crisis line, is we make sure you're safe. We don't want to tell you, hey, go get an appointment with a doctor. You can get in 2 weeks, and then a week later they hurt themselves or hurt somebody else. So we want to make sure you're safe and currently safe and get that resource referral that you need. We already talked about OSAR, outreach, screening, assessment, referral. And by the way, so I don't forget it, because I know it's kind of, we're going back and forth. Atlanta has carte blanche ability to print off these and any kind of information, pass these out. If you want to get copies of these, they're not proprietary. They're not putting anybody at risk. You can have all this on handouts if you want it. Managed care, again, those are people that have specific mental health plans that work within insurance companies or employee provided companies. And then we do the hotline services for 3 of those managed care in Texas. And then support groups. We don't use one right now. We don't have one ongoing. It just, after COVID, they just were not tenable to have a survivor of suicide or a survivor of trauma group. We tried to promote those, and people just they don't do well. Suicide recovery groups or suicide support groups don't work well on Zoom. You really need to have a knee-to-knee interaction with people when you're talking to them about that, because but there are some organizations in Tyler that we can refer you to for that. The emergency screenings, again, that's where we refer to hospitals. We handle those after hours because usually the mental health centers have their own screeners during business hours. But after hours, 5 o'clock till 7:30 in the morning, we get a call in the catchment area. We would put them on the line with one of our screeners. We would do what's called an emergency assessment. Then if that's, we give that recommendation to the doctor or the jailer or whoever is the caller that's requesting that, or even a client in their home. Now we do those in the homes, and we may tell them go to the ER to get medically cleared, or if they've got insurance, they can go straight to psychiatric facility for inpatient. Let me talk to you about this. This is a long used acronym. We don't use it a whole lot, but it's pretty comprehensive. And I think if you've never seen it before, it'll do you some good. It's just the words, is the path warm? Is the path warm? So you want to ask yourself and kind of have these antenna up about risk when you go in to see a client at home. And what's your normal contact with a client in the home? How does that start? How do y'all get triggered or dispatched to go to a home?
Talk to a caregiver for starters. We're required to see our child once a month.
Okay.
Face to face, unless they're but over 300 miles away, then you've got every 6 months. But
gotcha.
So it's, and then the one I just call the caregiver.
Okay.
Say when you guys available, and we set it up. That's simple as that.
And you're screening them to help educate me. I apologize. You're screening them for physical needs being met, emotional, how healthy they are emotionally, things like that.
Yep.
Okay. Then this would be
the place they're staying in,
okay.
Caregivers care, that kind of stuff.
Gotcha. Okay. Yeah, they get into school, dressed right, being fed right. I got you. Kind of a comprehensive eyeballs on them and
our job is to be advocates for the child.
Gotcha.
So we can make recommendations to the judge.
Yeah.
And then he can choose to write it in a court order or not.
Right. Okay. That sounds pretty simple, right? You're going, yeah, come right along with me. Well, here's something that you might put in the back of your mind. Sometimes we look at risk screening as being pretty simple. Are they suicidal, homicidal, or psychotic? And that's easy. You know, if you're one of those three things, you get screened. If you're not, you're okay. Well, that's not really true. If you look at is the path warm, there's a lot of times people will. In fact, there's a friend of mine named Jack Klutz who wrote a book that he said that there was a young man, and I'm not trying to be dramatic. I just want to show you what I'm talking about. There's a young boy who was talking to his grandmother on the Zoom call. And she goes, how are you doing? Because he'd been depressed, had some problems in college, I think. He goes, oh, I'm doing great, Grandma. And what are you doing? Well, I'm cooking Sunday dinner. Are you going to be here? I'm looking forward to it. I love you. Okay, bye. And she ended the call. He didn't turn his Zoom call off. He walked over and ended his life with a firearm.
No.
Right after he got off the phone with his grandmother. So you can't say just because they're cheery, happy, and presenting that's the only factor that you weigh when somebody has a potential to hurt themselves. What's he going through? Did he just have a breakup? Has he had a drug problem? Did he flunk out of school? I was at Latino University, very high academic standards. We had numbers of clients that would go down to a local river and end their life because they were failing, which is crazy that you would think that much pressure on academically, but it was a high academic environment. You know, our basketball players would come over and play TJC and the guys would say, oh, these are the brainiacs, you know, from Laterno. And I'd say, yeah, every one of those starting guys is carrying a 4.0 in electrical engineering, you know, which is not your usual athlete. But there's a lot of pressure when you see that. So you don't know when you go into that home what kind of pressure that you have. So let's look at is the path warm. First of all, ideation. And I'm going to try to stay on time because I could jabber a long time. So I stands for ideation. It's a thought of suicide. There's no plan necessarily. There's no time frame on it. You may write down and say, look, I'm sorry, but I just don't want to be here anymore. That would still be an ideator. Okay. If there's not a written plan, you know, when you find me tomorrow, know that I did everything. You know, that's a plan. That's a distinct time frame. But an ideation is just somebody that has passive or passing thoughts about hurting themselves or hurting somebody else. Okay. Now, substance abuse is another risk factor. Are they using drugs? Okay. I know that several people have been taken out of homes, children. I know I've heard the stories about how young substance abuse is in children. My sister worked with CASA up in the Fort Worth area for a number of years. It's amazing that 9-year-olds would test positive for meth. And it's amazing. You wouldn't think that would be a possibility in today's age, but it absolutely is. And I'm not talking about accidental contact. I'm talking about ingestation.
That is because the mother was an addict herself.
So, I mean, a lot of it, but I'm just saying there to say that a child at 9 or 10 years old is not open to using drugs or being exposed to drug use voluntarily is to be not having your eyes open, because it absolutely, I'm not saying it's a normative, but to have it happen, it's absolutely a possibility. So I don't know, do they age out of CASA at 18 or 17?
Yeah,
Okay. 18.
Possibility of staying in programs until like older, but yeah.
Gotcha.
22, I think, 21.
Gotcha. Okay. Here's the I, that was I, was the ideation S, substance abuse. P is purposelessness. I've heard, especially in geriatric care, and you see this in caregivers, I just don't know why the Lord's left me here all these years. And that's, I've heard people say that all the time. But in connection with some other risk, it can be there's no reason for living. I have no sense of meaning or purpose in life. That's a risk factor. That's a very, if I hear somebody, and I'm a counselor and I talk to hundreds of people a week, and when I hear them say things like that, my ears perk up. My ears perk up, especially like in jail. I had a guy in one of my group hung himself, didn't complete the suicide, was in the hospital for about a month, and finally they pulled life support on him. But he was purposeless. I don't know what I'm gonna do. I'm in jail and never gonna see my family. I don't know why I've still got you. That's a real risk. That's not just, he's not just saying that because he's in jail. He's saying that because he's in jail. He really does feel like he doesn't have any more purpose. He's looking at a 50-year sentence or a 70-year sentence, and he's 40 years old. So he's going to die in jail. So anyway, so purposelessness. A is anxiety, anxious, agitation, nightmares, inability to sleep. You'll see that with children, especially with trauma. They've gone through some kind of sexual or physical or emotional trauma. You'll see anxiety. And it's not just hyperactivity. A lot of times people mistake ADHD or ADD for, and it's trauma. And I know y'all probably done some training in trauma-informed care. I know that's a big thing in advocacy groups. So we need to know about that. Anxiety. So what's that? They feel trapped. Well, I can't go anywhere else. I mean, domestic violence. That's a key factor in that. Well, I can't leave my kids. Where am I going to go? I'm not going to live in a shelter. I don't have any money. I don't have any people. I've moved here from out of the country. I moved here from out of state. Where am I going to go? So they feel like they're trapped. They would rather end their life than stay in the situation they're trapped in. So be aware of that. Hopelessness. We talk about helplessness, hopelessness, haplessness. They don't have any tethered plan in life. They don't feel like anything's going to change. And so that's they're hopeless about themselves or others. My husband's never going to stop hurting me, or he's never going to get a better job, or we're not going to get out of this hellhole. And so notice when kids would voice hopelessness, but also when your caregivers voice it, because your caregivers sometimes are just as purposeless and have just as much anxiety, feel just as trapped. And so don't feel like you don't need to understand where they're at too, because the health and safety of that caregiver is the health and safety of that child. So withdrawal. Are they isolating? Are they staying in the room? Are they not talking? They used to. They're not playing ball anymore. They're not coming out. They're not happy. They're not playing with friends. They've withdrawn or kind of live a reclusive life. That starts pretty young, especially in, y'all know this, in sexual abuse. That's one of the main, they'll start to withdraw socially. That's a big factor. And then anger. Some kids get angry, when you discipline them or whatever, but people that just have uncontrollable rage, outbursts, it's that's unnatural for children that have a general sense of well-being to have that kind of rage. That's not, we made it common in society, but it's unfortunate that we've normalized that. But they seek revenge for perceived wrongs. Used to, Billy did this, I think he ought to get grounded or whatever. Now you hear children say, Billy did this against me, I want to just kill him. And you'll hear things like that. And so we can't not act on those things or be aware of them, because there's been children, this, you've heard of it, where they've taken firearms in the home and shot a sibling or shot another child in the home. So be aware of the anger. Recklessness. They're destroying their iPhone and don't care. That should be their prized possession, and they break it and it's like, I don't care. And so they're reckless with things. They're acting in a disregard for the consequences. I used to tell people the most dangerous thing you'll ever hear is a 12-year-old boy saying, "Hey, watch this," because he's fixing to get hurt. So here's something. Y'all getting a little too serious. What's the fastest land mammal on the earth?
Oh, I know that.
What's the fastest land mammal? No, it's not. It's a toddler that you just said. What did you put in your mouth? Okay, yeah, that's good. That's a good one, though. All right, so recklessness and also mood, just a dramatic change in mood. You know, they're usually very happy, very funny, and then all of a sudden there's this mood. Or maybe it's lab-all effect. They'll be laughing one minute, crying the next. So watch their mood, be aware of that. And I know seeing them once a week, once a month, or twice, it's hard to get a read on that, but that's where the interview comes in with the caregiver. You can ask them those questions. I know you don't talk around the child, you talk to the child. I get that, but there's times when you need to get that history or get what's going on. I don't know what a normal visitation is, if it's 45 minutes or 4.5 minutes, 45 minutes or 4 hours. I don't know, but spend enough time to look at some of these factors when you're talking to them. Suicidal warning signs. Let's talk about suicide. People that kill themselves generally, and there's never there's never a successful suicide. Okay, there's completed suicides, but if somebody ends their life, there's nothing successful about that. And so I know that's a little nerd thing I talk about, but I don't like hearing people say that. The more of these warning signs that you'll see, the greater the risk. I always tell people, believe people when they tell you something. Believe people when they tell you something. If we just say, oh, they're just acting out. Oh, they're just saying this. And I think I've got it down later on the slide, but the youngest suicide, threatening suicide that I screened personally on the phone was a 5-year-old child. And his mother walked into the living room. He had a pair of scissors up to his temple and said, I'm going to kill myself at 5 years old. So don't think that they're too young or they're just acting out, because it's sad that we're in a society that has those kind of crisis. Anyway, suicide warning signs, the way they talk. If a person talks about themselves either killing themselves, having no reason to live, being a burden, feeling trapped, or just unbearable pain. In fact, it's been said most people don't end their lives because they don't want to live. They end their lives because they don't want to feel the pain anymore. That's why they end their lives. Okay, they don't want to feel the pain. And so look at these warning signs. And again, we'll make them available to you. There's also these are the warning signs of behavior, not just talk. Your language, what you say is important, but also what kind of behavior do they have? Increased drug use, looking for ways to kill themselves, searching online, check history. I always tell parents this: be the biggest snoop in the world on your child's online presence. Do not say, well, I don't want to invade their space. Parents, invade their space. Okay, you may save their life. Okay, so yeah, I believe in giving children their privacy when it's needed, but I like Reagan said, you trust but verify. Trust your child but verify what they're saying is true. So that's behavior. It's like that couple of kids that were homeschool kids, and so they didn't have a big school or a social circle. They just had another homeschool. The little boy and the girl had planned to run off together, and so they were perfect kids. They went to church. They were doing good in school, making good grades. And they came in because their parents wouldn't let them see each other. The young boy came in and shot both the parents. The grandparents is who was keeping them. They got in and stole their car and were 2 states away before they found them.
How old were the kids?
And 13 and 14 years old.
This is true.
The true story. Yes, ma'am. And again, I know this sounds very horrific, and I talk about it because that's the world we live in. I hate it that it's so that it's so normative. But what I'm saying is, I want us, sometimes we have to be awakened to the risk, because it never happens until it happens. Okay, it's public, so I can tell you this without breaking HIPAA. There was I don't know if you heard about the law officers that were just arrested for sexual. That it was the father, 3 sons, were sexually molesting a 9-year-old up until the time they were grown, taking videos of it. 2 of them were police officers. So
Is it Smith County?
no, it was actually Gregg. It was Gregg County. So it was local. That was local. It was a male child. is a male child. So anyway, I say that because it happens. It's in the news. It's going on, and the at-risk children sometimes are at risk more than just the at risk you see. You know, a divorced couple or a domestic violence or a drug addiction, a child's removed from a home. Sometimes that one or two factors is not the only factor they're being exposed to, because at-risk kids are at risk. And you've gone in to see some of these homes that you wonder if it's better for them to be there or someplace else. I understand that. And I'm not saying to be suspicious of everybody, but be aware. Just look around. The risk factors for suicide risk also, health. Are they healthy? Do they have chronic illness? The environment, is it a bad environment where they have, too many kids, high conflict areas? And then a history. Did my dad end his life? Was he a drug addict? Was my dad a abuser, domestic violence? Okay, so look at all those things. And I know this is a lot. I get it. I'm just gushing on you, and I'm doing so because I really want to just touch base on these. And if some of these pique your interest, I want to give some time to talk about those individually. And then health conditions, substance abuse, and then chronic conditions. We've already talked a little bit about trauma-informed care. You can trigger people in a way you don't even realize just by bringing up a subject sometimes, by approaching it in the wrong way, treating it as casual when they are very serious about it. And anyway, that's trauma-informed care.
In Canada, they actually have a program now that you can, if you're in extreme pain and you don't want to live,
Yeah.
you can actually go, and it's clinically,
Yeah.
protect you.
Yeah. No, I get it. I get it. And one of the things that we had a few years back were these suicide pacts. We call them contagions. Little Susie ends her life, and then little Julie ends her life, and then her boyfriend does it. And then the next thing you know, they got 5 or 6 kids that have ended their life because they go, yeah, I feel that way too. And it's crazy how that works, but it works. It's not a, I think it's working now. Good. Now I can do this. But a contagion, that's what that means. It's always like a contagious disease. Somebody commits or completes a suicide, and then the next thing you know, it's like water under a rug. It'll just run through a school. And that secondary trauma is you've noticed this probably, that especially in females, because they're a little more in touch with their feelings, that some kid will die in a car accident in the school. And then a girl in another grade that's never met him will just be broken up about it. Why? Because her friends were broken up, and so they share that trauma and they share those emotions. So you have to be careful with children. They haven't got to that point of being able to compartmentalize that as well. Access to lethal means. Watch for single parents, rural residents, access to firearms. Okay? You got to be real careful. There's countless stories about a single parent being at work, and that child knows exactly where that firearm is and can play around with it, or they can use it. And so anyway, we are in Texas, and we have firearms, but you just got to be smart with them. Lock them up, keep them, make sure they're out of reach. Prolonged stress factors, multi-generational homes. Now you got grandma, child, adult, child with children. You got 2, 3 generations living in the same home, creates a lot of stress. Immigration status now, especially in our current political environment, it is, no matter what side of the road your ditch is on that issue, we can all agree that that's a high stress and a high volatile situation right now. Okay, and everyone, from our law enforcement to our caregivers to our children. So those are stressors. And then stressful life events. Somebody's going through a tornado, a hurricane. We got all the Katrina victims years ago that came in, and we saw what that was when we had the kids in school that were really in a bad way after that. Previous suicide attempts, family history of suicide attempts. My grandfather took his life. He had tuberculosis and didn't want to be a drain on my grandmother, and my father. And so he ended his life. He knew he was going to die, so he just went and killed himself. But my father carried that with him. He would tell that story. Now, he wasn't affected by it from the standpoint of attempting, but yet it was definitely a risk factor, for him. So the typus, I don't know that we need to spend a lot of time on this. There's a non-ideator, which is I'm just going to kill myself. You took away my phone, and he never thinks about it again. That's a non-ideator. It's an impulsive. An ideator is they have thought and they think about it. Maybe they have a plan. Maybe they have and then you have an attempter, that somebody that actually tries to cut their wrist. They'll overdose. They'll use a lethal mean and actually make a attempt. There's those that have an insincere attempt. I'm going to take my pills and I'm going to call my mom and tell her I took them, so that she'll rush over here to save me. They really don't want to die. And then insincere, non-lethal attempt. In other words, I'm going to cut myself, but it's just going to be a scratch. I'm going to overdose on aspirin or something where it's not they know it's not a lethal attempt. But here's some suicide myths and facts, and these are way too long to go through all of them. But just to give you an example, myth: suicide people are fully intent on dying and nothing others can do or say can help. Well, that's suicide is preventable. That's not true. That's a myth. It's preventable. Most people don't want not to live. They just don't see ways out of their issues. They don't see ways out of ending the pain. And so to think that, well, if they're going to do it, they're going to do it. That's not true. And next one is suicide happens without warning. Nope. There's generally, I tell people I use this as a visual. I'd say if this is suicide right here, this little 4 plate, and I'm back here, I'd walk up to that line several times before I step over it. Sometimes I'll go to a location, I'll practice it, have pills in my hand, whatever that is, but you'll get closer and closer and closer. So it's not a big jump. In fact, it's just a little step because they've walked up to that line over and over again. You got to hear that when you're interviewing or talking. Improvement in a suicidal person means the danger is over. Nope. Many suicides happen several weeks or months after the beginning of improvement. Here's why. They know they want to die, but they feel bad. They feel horrible. They'll get on psych med and suddenly feel good, and they'll go, yeah, I can end my life now. And they'll take their life after they get feeling better. It happens all the time. And it's crazy, it's counterintuitive, but it's absolutely right. Okay, because they're not even motivated to complete suicide. And when they get on medications to get feeling better, they do that. So let me because we're going to hand these out, let me move on through these. So I don't want to.
5 to 10 more minutes, and you're good.
Huh?
5 to 10 more minutes.
Okay, good. All right. Here's just some numbers. 49,000 people every year in America die by suicide. There's a suicide completed every 11 minutes. It was the 11th leading cause of death in 2022. It may be 13 or 12 now because of fentanyl, but still that's poisoning overdose. In the method of suicide, half the time it's firearms. The reason that's the case is that you don't kind of attempt suicide with a firearm. Usually you complete one. And then the women are most often poisoned or overdoses. Talk about who's at risk. What should I do if I encounter somebody? I'm going to give you all these. We're talking about imminent danger. I know there's a lot more here. You can say grace over. I get it. There's this one here. When you get your handout, or Atlanta can maybe make copies of this. These are the counties in your crisis line, your local crisis line that you can get a hold of if you do have a client at risk. And again, if your protocol is to call your supervisor or whatever, do that. But if you find yourself in an imminent risk, you just don't want to call the police, you'll think it's necessary. These are your crisis lines for both the Andrews Center for the counties that y'all cover. And then this is our website. There's some other resources for suicide prevention that you can go